drugs, electroshock, and biochemical theories, the new psychiatry, by Peter R. Breggin. Dr. Peter Breggin, he is a psychiatrist in Bethesda, Maryland, where he has been in full-time private practice since 1968. Harvard educated, he was a former teaching fellow at Harvard Medical School and full-time consultant with the National Institute of Mental Health. He is currently the professor of adjunct of conflict analysis and resolution at George Mason University and the director of the Center for the Study of Psychiatry. We start the chapters under the title Shock Treatment is Not Good for Your Brain. We start with two sets. First is by Ernest Hemingway. He said, "Well, what is the sense of running my head and erasing my memory, which is my capital, and putting me out of business? It was a brilliant cure, but we lost the patient. It's a bum term, Hodge terror." This is by Ernest Hemingway after ECT and shortly before he shot himself, quoted by A.A. Hutchner in Papa Hemingway, 1967. If we start, electroshock is an psychiatric of the passage of an electrical current through the head and the brain to produce unconsciousness and convulsion. It is estimated that nearly around 100,000 or more Americans are being shocked each year, and the number is rising rapidly in the United States. Let me start with two survivors of the ECT and to show how much this ECT is harmful to your brain. First one is one lady called Cynthia. She was an extremely intelligent young graphic designer who had taught courses in her field before completing her schooling. Had been rendered permanently unable to teach or to work following a routine course of shock treatment, ECT. The ECT method used was state of the art, but her once high IQ was now severely reduced and impaired. Shortly, this lady was very brilliant, very active lady. After this course of ECT, there was a gap in her IQ, and her memory was not functioning any better anymore. This is reflected in her social relations, so we could see how her personality and cognitive functioning have been affected severely and badly by the ECT course given to her. Not only that, it has been documented by the CT scan that she did show shrinkage of the cortex of her frontal and temporal lobes, and the neuropsychological testing also showed generalized brain dysfunction. We go to other example, other person who called Manfred, who was who lost his wife and developed depression after that. And the ECT was given to him, which added to his psycho-spiritual loss. In fact, Manfred tried to ignore or to make light of his mental dysfunction. His family and friends even noticed that he developed severe memory blanks for even during the year or the 2 years prior to the shock, almost complete memory loss for several months around the shock, and difficulty grasping or recalling new information and ideas. I evaluated Manfred, and my clinical impression was generalized brain dysfunction with memory impairment, relatively shallow emotional responses, poor judgment, difficulty with intellectual functions, and problems focusing his attention even. He had dementia, global mental deterioration caused by the shock treatment. In fact, the most of his symptoms, if we look to it, it could be summarized in what we imagine as a frontal lobe syndrome. He developed the neuropsychological testing, which confirmed the diagnosis of brain damage, showed shallow feelings, inappropriate conduct, and obvious intellectual and memory problems. In particular, they said he have no longer the same mental acuity, ability to plan ahead, judgment, and insight in social situation. Thus, he had symptoms of frontal lobe syndrome, in fact, after this course of ECT. Everybody of his colleagues, of his family, of his friends, did understood that Manfred had been changed completely, personality and his cognitive functions, except his psychiatrist, who was conducting the ECT. He was not seeing no change on Manfred, in fact. Survivors saw that offense against ECT and the outrage in the United States started to be taken by the survivors of ECT. The people who survived from ECT and from this harsh treatment and insulting treatment to the brain, they are the people who took the offense against the ECT. Even a lady called Angina Alioto, she is the chair of the City Services Committee of San Francisco Board for Supervisor. She called and she supported to hold a public hearing on the ECT in November 1990, and the author of this textbook was invited there. In fact, all the people, 4 psychiatrists was there, and they were trying to show and advocate the ECT and support its use. I was the only one, the author of this book, standing against them. The whole room was full with or packed with outraged people who had signed up to be to have been outraged and against the ACT and to show that the harm done to them. Nobody, of course, could stand and show how much the damage done to him because mainly of the reality. It is most difficult for the patient to come forward in this hearing, and they have been to show that they are injured by the treatment because they must face not only the stigma of the mental illness and the shock treatment, but also the stigma of the brain damage done to them. So most likely this patient was not likely to stand up. This lady, the Angela Ryuto, have been invited by some of the psychiatrists even to attend the ECT sessions. They want to show her how much it is safe and to be done. She has been invited to attend the ECT sessions and to see it, and she, when the patient already was anesthetized and given muscle and was given muscle relaxant at that time, but I asked her to attend and to meet series of this patient who have been shocked several times, and to attend and to see and to evaluate them just after the ECT, and to check how much it has been affected. In fact, reporters frequently have been invited by one of the best-known shock advocate in there, called Max Fink, to witness the patient being given the treatment. I have urged media representatives to ask Fink to allow them to see his patient after they have been receiving a full course of shocks. Not only to see the patient just receiving the shock. It's not the problem we are looking for. We want them to be evaluated after the shock. Under pressure, Fink has agreed, in fact, but with a catch. While he charged nothing for the media to watch a patient undergo the procedure, he decided to charge $25,000 for himself and $15,000 for the patient, a total of $40,000 for a single interview with the patient awake after the course of the treatment. So far, no one has taken up the offer, and when it was reduced on one occasion here. But this is just making difficulty for the people and for the public to attend this survival after receiving the shock. Even I have urged this lead to cut off the funds, the city funds, for any hospital trying to give the shock. So to limit this treatment, and I call the shock treatment an electrically induced closed head injury or an electrical lobotomy. If we look now in USA and compare it to the USSR, Soviet Union, we find that animal tests in the USSR Academy of Medical Sciences have shown brain damage with nerve cell death from the electroshock treatment. The Russian psychiatrist boasts that his country has placed grave limitations on the use of shock, while in the USA, for example, it is very widely used and has become all but a repressive measure applied even to healthy people. Even shock is celebrated. Now, just the last celebration was in 1988, after the 50th reminder or the 50th celebration of the ECD after 50 years, promoting the shock. In fact, in the United States, there is a lobby which tries to promote the shock, to keep it running all the time. In the United States, from these people like Gary Allen, who described the moment in the American Journal of Social Psychiatry, Allen called the circumstances both exhilarating and depressing. Exhilarating because legislative restrictions on ACT has been overturned recently in California. So there have been some sort of restriction on these ACTs, but it is a pleasure because further attempts to promote it again and to put it again at its action really. In fact, if we look to this guy, Adam, he's the co-founder and first president of the new organization who agreed to the revocation of his California medical license after being accused by former patients of sexually abusing them in an extremely sadistic manner. If you look to this person himself, from the people who have been even supporting and advocate is Max, one doctor psychiatrist is Max Fink. He was the editor-in-chief in the convulsive therapy journal. He sent off the detailed note that convulsive therapy is often attacked as intrusive and brain damage, and governmental agencies and some justiciars have attempted to interdict its use. He laments that teachers are called on with increasing frequency to defend its use. In the editorial, Fink does not mention that his own research, in fact, spanning 3 decades frequently, had compared electroshock to traumatic injury of the head and brain, and that often had asserted that brain damage and dysfunction are the cause of what's so-called improvement. So if it is not the science and not the improvement behind the advocation and promotion of the shock, what is it then? If we look to the economics of ACT, so and how much it is making the income of the psychiatrists in USA, we could understand something about why they are promoting the ACT. The total bill for a month's stay with shock treatment was approximately $20,000. Most of the cost usually is covered by health insurance. As psychiatrist David Viscott observes in The Making of a Psychiatrist, finding that the patient has insurance, if the patient has insurance, what he means, seemed like the most common indication for giving shock. So once the patient has insurance and coverage, the health insurance is the main indication to give him a shock. In California, individual treatments cost $1,000, with the psychiatrist who pushes the button often making between $200 to $300, although nearer 100, although some limit the payments to $100. So we can easily calculate the annual income of a psychiatrist who can generate by shocking an average only 5 patients a week, a typical charge of the $200. And he will shock, if we suspect that he will shock 5 patients in the week per treatment, and each patient will take 3 sessions, so his annual income of this shock only will be $150,000 a year. And if we add to it the visits and the work and the investigation done for the patient, it will make a total of $262,500 per year without using up more than a few hours of time. So it is in fact a huge income for the psychiatrist there in America. Such enormous financial incentives can wholly cloud the doctor's perception of whether or not shock is good for the patient. It is good for the doctor, in fact, not for the patient. It's not like our time is very limited, and not like to give too much stories on this and personal links, and that even some of the doctors make videotapes how to make shocks, and some are shared in the manufacturing countries with the ECT machines, and they get benefit from these videotapes and from these machines and from the income of these companies, and they get benefit even from outside the hospital. If we look who got shocked in America, in California alone there's around 2,500 persons shocked per year, and two-thirds of these people are females, and mostly of them are elderly females. If we look to these elderly females, in fact, most of them are alone, many living in relative isolation, and many barely making ends meet. I talked about the need to provide these individuals with psychosocial and economic support, not ECT. These are lonely, elderly, female, sitting alone, no support, no social, no economic support for them. They do not need ECT, they need social and economical support, not ECT. If you go and check to the number of the people who have been receiving ECT in California, of this 2,500 persons, we will find 2/3 of them are elderly females. And if we look to them, if they have depressive symptoms, it's not attributed to the endogenous depression as they claim. No. In fact, their social and economical status. What they need, the social and economical support. So ECT, as claimed by some psychiatrists like Donald Hay, who said ECT as the first approach for the depressed elderly patient. In fact, there is no mention whatsoever of any method of help other than drugs or shock for the depressed elderly. This illustrates the principle that your doctor's condition, rather than your own, determines whether or not you get drugged and shocked. If we look to the impact of the shock treatment, the electroshock or electroconvulsive therapy involves the passage of an electrical current through the brain of the patient to produce a grand mal or major epileptic seizure. Sometimes the two electrodes are placed over both temples, bilateral shock, and sometimes over one side of the head, which is called unilateral. The shock induces an electrical storm that obliterates the normal electrical buttons of the brain, driving the recording needle on the EEG up and down in a violent jagged swings. This period of extreme bursts or electrical energy often is followed by a brief period of absolutely no electrical activity, called the isoelectric phase. The brain waves become temporarily flat, exactly as in the brain death. And it may be that this death takes place during this time. As a shock-induced seizure is typically far more severe than those suffered during the spontaneous epilepsy, the normal epilepsy. So what is induced electrically is far more severe than one happened naturally in the people. Even if we look now to the modern ECT, what they call the modified ECT, in fact it's not making any use, it's not useless. They are giving now ECT under effect of general anesthesia, and under muscle relaxant, in this condition they have to raise the threshold of the electricity given to the patient, which is making no benefit and does not. So in fact, now we are sure that it's the brain gets suffering from this ECT, and whatever so they did by anesthesia or muscle relaxant doesn't make any much better for them. If we go back, even we'll see some psychiatrists, they have been abusing ECT to erase the memory of some people by me. They intend to do, and they give very intensive multi-monitor ECT, ECT, just to erase the memory of some people. And there are some stories here in this book illustrating that they have been using this to erase the memory of some battered wives, to erase their memory and to reprogram some people. And even some agencies like the CIA have been using this manner for some of the people, erasing their memory and to reprogram them. Rather, it's just like a brainwash. And some psychiatrists even have advocated this.
Okay, thank you very much. Okay, shall we start? Thank you, Professor Bergen. We'll start. Bismillahirrahmanirrahim. To start with, just a comment on the paper, then I will have to talk briefly at the end. In the talk, the first statement mentions very well what is the sense of reuniting my head and raising my memory. This is by Ernest Hemingway after ECT and shortly before he shot himself. From clinical experience, we know from these simple few word description, this patient most probably was depressed, and the ECT was given to him. The activity aspect, I mean, the psychomotor activity was improved, and then he commits suicide. This is well known in psychiatry and clinical practice. And it is not an ECT who made a suicide, it is a depression. See? Most probably, this was the patient was severely depressed, and this is why after ECT and initial improvement, he attempted suicide. Then another description, also by a neurologist, you did mention, Dr. Abdelrazak, by a neurologist, he mentioned that the ECT effect resembled punch-drunk boxer initially, and then a lot of neurological manifestations. This is biased because he's a neurologist and he is seeing neurological cases. As we know, in neurology, a lot of neurological deterioration, most probably chronic deteriorating courses running on whatever medication is, and most probably ECT was given transitory for a transient depressive episode during these running long-term neurological disease. And the ECT is not the one responsible for these grave prognoses. Actually, most probably the initial neurological problem. And he mentioned the finding, he mentioned that like punch-drunk boxers, we go to the neurology book. Neuropathological studies of dementia pugilistica, which is chronic traumatic encephalopathy of punch-drunk boxers, shows evidence of degeneration of substantia nigra, hypothalamic anomalies, cerebellar folia, and this is not present in patients receiving ECT by any proved studies till now. These findings present in these sort of cases, but not present in ECT. If he said this is due to ECT, so where did the evidence of that finding? Then we go to some stories about two survivors, Cynthia and then Manfred. These illustrated in a non-scientific way. Where is the sociobiographic data? What's the presenting complaints? What is the cause of the illness? What is the diagnosis? A lot of confounding factors, and you have to know before deciding he was eligible to ECT or not, and what sort of disease he was having before. But making generalization, just mentioning just one name, and then mentioning that he received ECT and he was deteriorating, it is not scientific statements by any means. Then also he mentioned CT scan finding, shrinkage of cortex of frontal and temporal lobes. Most probably this is, as I mentioned before, related to the pre-existing neurological problem rather than ECT. As I come later, we'll find evidence from the recent articles. There is no any evidence for structural brain damage from ECT. Then, at the end of his example, he mentions some interesting findings. He mentioned anosognosia, and he attributed to the ECT, and he used these anosognosia that the patient is not aware of what's happening after the ECT, so they are not, asking for their rights. No, this gives us a hint that this is most probably neurological disorder. As we know as a clinician, anosognosia commonly found in neurological disorder. So this gave us a hint. Knowing that, we don't know all the description of the case, but he's mentioning that there is an anosognosia. Bring our attention to the neurological disorder rather than ECT complication. Then he mentioned about Manfred's case and the chronic deterioration and long, global mental deterioration caused by shock treatment. The same problem is it is not scientific because we don't know what's the diagnosis and what's the clinical presentation was. And most probably this is related to pre-existing disease rather than ECT or shock treatment, as he mentioned. Then in the later example, he mentioned that symptom of frontal lobe syndrome, and he gave a elaborate description of the clinical presentation, typical frontal lobe syndrome. All the non-biased studies done till now about the structural damage, there is no mentioning of frontal lobe injuries as he described. And this is not proved by any means, by any scientific study till now. So this also give us a hint, this is most probably related to pre-existing neurological problem. He commented then, I have found this time and again, everyone recognized that the patient has been damaged except the psychiatrist. This is his personal comments. It is not scientific statements. lacks validity and reliability. Survivors take the offense, and he mentioned that the lengthy literature documenting brain damage from ECT, including animal and human studies, go unmentioned. This is not true. If you go back, unbiased, making any sort of search, computer search, whatever, we'll find a lot of literatures. If it's scientific, we have to mention all the studies with and against, then we compare at the end. Not mentioning only what is, mentioning that there is brain damage and ignoring the other studies. And this is not scientifically accepted. Then, yes, also about the story of he went to give a lecture in with 4 psychiatrists, and all audience were having outrage and angry about the ECT. We are, in scientific speaking, we are not depending on the public opinions or public attitudes. We are public on the data, scientific data proved by studies. Also, he mentioned that the psychiatrists are not giving opportunity to interview in shock treatment. If it happened in personal experiences, one, cannot be generalized to all psychiatrists. And from clinical experience and also from the studies, it is open for studies and for follow-up for research purposes. And this is, we can smell from it, persecutory ideation towards psychiatrists. And also he mentions the electro-induced closed head injury. He meant to mention, to name the electric ACT, electro-induced closed head injury. No scientific ground of these says. This is only his comments and his opinion. And then he mentions about the comparison between what's happening in the United States and Russia, and based on the animal test in Russia, academic of medical science have been shown brain damage with nerve cell death from electroshock treatment. A lot of studies done on the animals, and initially it was conflicting. Lately, according to computer search also, there is no documented structural brain damage. But the explanation of the earlier studies, actually many criticism about that earlier studies which document some of brain structural damage in animal level. The current was very high, which is not practically the same as what we are practicing or using in for clinical purposes. The second things, the differences in the brain thickness and brain tissue and ratio differ from the animals and humans. We cannot generalize the finding we have been concluded from animal study to human study. In spite of that, there is recent study proved no structural brain damage. Then he mentioned about many scandals and personal misbehavior of these, some of the authors or some of the advocates for ECTs. This is not related to the ECT. This might happen to any specialty, any doctors, even outside the medicine. They have personal scandals. What's the relation between the personal issues and scientific well-based information? So no point to mention these stories. Then he mentioned about economics of the shock. If we think about, let us say, private hospital, so we might accept it to some extent, or even if there is health insurance, we might accept it to some extent. But we cannot generalize this finding on all psychiatrists. All psychiatrists have no conscience to how to select the cases and what's the benefit of the cases. The original aim and the basic aim for the treatment of the patients, not to introduce harms without any reasons. And a lot of figures, 150,000 and etc. This is actually short-sighted view in assessing the concept of economic and ECT, ignoring medical indication, ignoring other aspects. Then he mentioned that Yes, who gets shocked? He mentioned mainly elderly and female. As we know, electroconvulsive therapy, giving in certain indication we discussed earlier in the last presentation, mainly depressions, and depression commoner in female. That's why it's commoner for female. There's not any persecution against female, but this is natural. Then why elderly? As we know also, medical point of view, elderly have more organic or physical disorder higher than the younger. So, in treating depression in elderly, you have to take into consideration of these existing physical disorder. And the safest one is the ECT, because it is the least and side effect sort of modality of depression in this category of patients. And this is the explanation why elderly and why female more. And regarding mentioning other modalities, psychotherapeutic approach and improving social conditions, this is another issue. There is no contradiction between application or implementing these sort of supportive psychotherapy or cognitive behavioral therapies or whatever sort of therapies and biological therapies. Each therapist has its own indication. So this is not the point against the ECT. Then you mentioned that impact of acute organic brain syndrome or delirium. This is we know as temporary side effects in the first few hours or rarely few days after giving ECTs, which is reversible, and not like he mentions in magnified ways that it is something very difficult and disastrous. Regarding the evidence of permanent brain damage, I mentioned earlier about this issue. The damage is the cure, and he mentioned that the cell death is the core issue and the improvement. This is not true. The aim, as the recent studies, is toward more sort of neurotransmitter changes, which resembles what's happening in giving the patient antidepressants. In spite of that, it is not truly typical like the antidepressant, but there is a lot of changes documented by recent biological studies that a lot of changes resemble what's happening with antidepressant and ECT giving to these depressed patients. ECT used to erase memory, this is not scientific and this is not medical. We never use these sort of things. Our indication is purely medical on scientific grounds. Then he talked about CIA and the topics or issues related to the political power and influences. And give the impression that ECT was given by psychiatrists as auxiliary forces to the government to control people or to the prevent complete absolute freedom and to prevent them to express themselves. If the ECT is used for these political reasons, they control people or to control people freedom, how you prove these? How you prove this initially, and then we know from the statistic we have, 95% of the psychiatric patients are treated outside patients. Only 5% treated in inpatient treatment. It is cannot make it it is not going with what he claims. Actually, it is as restraining power against the population. We know nearly about 95% of psychiatric morbidity treated outside the hospitals. Only 5% treated in the hospital. If the claim is okay that we are using ECT as power to influence people or to prevent them or to control them thinking or thoughts, this is not going because the patient is not with us, not under restraint and it's not under the lock. The patient is going outside, and using ECT in clinical indication, not like in the case in the institutionalized patients, which have to be previously. At that time, you can say yes, it might be, but now the trend is against that. Let us go to the yes, he mentioned at the end. Initially, he was giving the impression that all patients undergoing ECTs will become having a lot of neurological complication and memory loss and apathetic, and they are not able to stand to ask for their rights. And then he mentioned something interesting. Happily, I also knew a number of survivors who have recognized the damage, but triumphed over it and to lead full, rich life, often as activists against psychiatric abuse. He's contradict his says, initial says. And then he said clearly the main attitudes expressed for psychiatrists giving ECTs those of hostility and punishment. Who is giving the punishment and hostilities? Who's the criminals? The psychiatrists who treat the disorder and alleviate the patient's suffering and bring the patient back to normal life and normal functioning, or who's leaving the patients for suicide, for risk of suicide at any time, or at physical consequences of these sort of complications, as well as mental deterioration. Okay? The end we can, if we are going to make our judgment on ECT, we have to answer certain questions. Is it dangerous? The latest mortality rate is 0.002% to 0.01%, which is similar as the mortality rate of general anesthesia. Then, is ECT have serious side effect? As we mentioned, all the side effect is temporary and transient, compared with pharmacotherapy, which might have long-term side effects. So also this topic or this item is managed also. And a lot of arguments regarding to prove the evidence, the scientific evidence regarding the investigation-wise. I also have the reference of it. Then is it effective and giving a positive result from clinical experience and also from research? We have we know the usefulness and effectiveness of ECT. So why do people have negative attitude toward ECT or against ECT? Is it fear of that this is invasive procedures? No, surgery is more invasive than ECT. Open head surgery, open brain surgery, removing and tissue and tumors, more dangerous and invasive than this. Later topics we can discuss with they have some points we can discuss at the end. Okay.
Okay. Why don't you just take 5 minutes and either question him or rebut him.
Okay. Thank you very much for my colleague Max Fink. He's very good at ECT. And I hope he will not lose his income. His income will be continued. In fact, you said there is no history of there is a huge literature on the effect and bad effect of the ECT on the brain. There is one here, for example, in 1952 by Hans Hartelius published a book-length report called Cerebral Changes Following Dialectically Induced Convulsions as a supplement to the Acta Psychiatrica Neurologica Scandinavica, volume 77. He found scattered cell death and small hemorrhages in the brains of the cats following relatively small doses of cats, almost without exception, merely by examining their brains microscopically. He was able to predict while animal had been shot. So there is an evidence and it's been hidden from the public.
Yes.
And the ECT people, they are very strong and they have their own lobbies, and they are carrying these lobbies even they are affecting the most strongest and powerful agencies in the United States. The FDA, the Food Drug Administration there. The ECT machines was classified in the class 3, which means they have demonstrating an unreasonable risk of illness. In the beginning, in 1979, was under class 3, which means they have demonstrating an unreasonable risk of illness or injury. Class 3 is the most restrictive category for medical devices and would have required manufacturers to provide pre-marketing data on safety and effectiveness. This probably would have necessitated renewal animal testing. So it was unreasonable risk of illness. Later on, by the American Psychiatric Association, first was put in the class 3. Under the effect of this association, it's the most strongest association almost in America, they put it in class 2, which approving them as safe and effectuous and requiring no testing. It was a clear-cut illustration of psychiatrists losing strength at FDA. So they are very strong and they could hide this information. Later on, by the outrage of the public and the campaign raised against the ECT, there was a compromise to put it. In September 1990, the FDA proposed a compromise that has satisfied neither side. It would classify the machines as class 2 for depression. And the psychiatrists would find their own way to classify the patient as depression and giving him ECT. So we could see how much they are effective to reduce it from class 3 to class 2, and the effect now of the campaign, the United States against them, and they are putting it again as class 2 with little restrictions. So they are very strong and we could hide this information from the public. Regarding the personality of the ECT doctors, I give you several examples. The time is very limited. And we could not run all these examples and these names, and they are very famous names in the USA, and they have in fact a sadistic attitude toward their patient. And the word they use, just let us hit him with it, just let us give him ECT, just let us punish him with ECT. This is the main words. And even any resident would like to stand and say, I don't want to give ECT, that means affecting his career. Almost his career will be stopped and punished. In the United States. It's very dangerous to do it, even to say it. Regarding the neurologist speaking in the first, he's a neurologist and he's well known. And he's as well his electroencephalographer. And this is his own statement. Nobody forced him to say it. And it's very clear. And 5 minutes were not enough to go over it again. You said it's in or outpatient. Yes, ECT is given for outpatient. Not necessarily. And it's still giving high income for the people. And it has been proven, most of this, like Max Fink and these people, have been shared in the companies manufacturing the ECT machines. So the looping effect of the ECT and the psychiatrists in America is very strong, and they could just hide this information. There's huge literature behind it. I give these examples, the Manfreds and Cynthia, just as an examples. Otherwise, there's a lot, and there is a lot of campaign in America against the ECT, and there is restriction even, I think, now by the government trying out. ECT is now under restriction, I think, in America. It's not used as common as before. Exposing the elderly females, yes. Elderly are more susceptible to brain injury than the youngest, and they need, I think, higher dose of the electricity than this is much more harmful to them. And if we work them, we would not even try to support them socially and economically, and we see what is the effect. Just we run with the ECT, which is the most easiest, and just to take their money, not to save them. Result of
okay. Okay. Regarding the first point, you mentioned one study, or even 2, or even 3. What about the total number of the studies throughout the global Earth mentioning the effect of ECT on structural brain damage? Does ECT alter brain structures? A lot of these well-validated control studies, at the end conclusion, there is no credible evidence that ECT causes structural brain damage. This is American Journal of Psychiatry, July '94. Okay, this is maybe biased. What about computer? Is a computer biased? Computer will bring any articles regarding, regardless, with or against ECT. This is the latest computer search from our library. I went through all these abstracts, and they are mentioning, frankly, whatever about written about ECT, whatever done in the last year, in '95. You can look, and everybody can look, the effect and usefulness of ECT and the negative result of brain structural damage. This is proof. This is computer, not biased. Then regarding the personality of the psychiatrist who is giving ECTs, you cannot generalize to all people. So whatever, how many examples you have, this is still an example. Personal examples or personal opinion, you cannot generalize to all. We have thousands and 10,000 of psychiatrists all over the global area. Then the third point about neurologists, I am with you. He's a neurologist, I know. But what he's describing initially this neurological disorder, and this is biased. We cannot get out this confounding factor. When we talk about ECT, you have to not to be biased. Bringing patients purely, and we'll see the effect of ECT alone without pre-existing neurological disorder. Then there is another point. I will take the chance to mention that. I mentioned that the ECT is not dangerous and no serious side effects, and it is effective and useful and sometimes life-saving, as we all know from clinical practice. So what's left behind? Why the patient is against ECT? I mentioned that it's not invasive, but sometimes they mention that it might be not humane, you see? If it's these issues, this is theoretical statement without looking to the reality, the aspect of humanity in application of ECT. What about amputation of gangrenous leg? Amputation of the leg is not humane, but this is gangrenous leg, otherwise the patient will die. Like here, in depressed patients, if we are not going to manage rapidly the patients, patient will have high suicidal risk. He's refusing to eat, refusing to drink. So his life will be affected. What about CNS operation? It is humane, removing whole tissues, sometimes lobotomies. This is not humane, but there is clinical indication. Like here also in ECT, we are not applying ECT to everyone, so there is restrictive clinical indication for its use. So the issue, I think, it's not that ECT is serious or invasive procedure, nor it is inhumane. The issue is because it is given to a mental disorder. What it is not accepted by some people, this is because the concept of mental disease, which they think the mental diseases are not medical diseases, so there's no need for medical intervention. This is maybe the basis of these statements and talk. Otherwise, as mentioned, it is ECT prove itself clinically, and when it's used, properly used in restrictive indications, give its better result without these serious side effects or abuse mentioned by the author. At the end, I want to remind myself and the audience that no contradiction between various psychiatric approach or therapeutic modalities. Supportive psychotherapy useful in certain cases from the start. Cognitive behavioral therapy is very useful in certain cases from the start. Psychoanalytic-based psychotherapy is beneficial in some cases. Pharmacotherapy and ECT as well useful when indicated and give dramatic results. So we have to be open-minded and to be eclectic in using various therapeutic approach according to clinical case presentation and according to its indication. Thanks.
Okay, why don't we just take 1 or 2 minutes for the final view. Does anybody have any questions of either of these?
To be honest, I think that this court is biased because of the evidences used by the persecution. They are using a book which is not scientific and doesn't show us any statistics or any scientific knowledge. And the persecutor did not try to elaborate in the information because he didn't have it, whereas the defense had all the information that he needed. Second of all, the persecutor himself, he used ECT. So how would I know that he was not biased and not bringing all the information against or with this ECT? Isn't it? So I think this is bias. Second of all, I want to talk about this book. This seems to be a kind of that what we call tabloid press or something of that sort. We can see that he's only talking about 1 or 2 cases with whom they came to talk to him. He's bringing some of the scandals of those doctors. Okay. Where is the big issue of humanity, which only the defense even mentioned it, but the prosecution didn't bring it. Those cases, which was all brought to courts in the States, why was it brought, and what is the scientific behind it to give more weight to this case? That's
Anybody else have any?
I have a question here. May not be very scientific, but came to my mind. When the prosecution talked about the thousands of dollars people making out of ST, I just remembered how much money did the author made from this book. This by chance only. How much money how could he made from such a book and giving it to people suffering or went with PCT before?
You're saying then that what difference does it make how much money makes?
Nobody knows. Yes.
Anyone else have any questions that might shed some light on this? Well, I think your point was very well taken, by the way. This book, as far as I know it, it is sold not really in medical bookstores. It is sold in department stores. I think that goes to show that elements of what you say is really true. My own feeling, by the way, I think you both did great jobs, wonderful jobs, both of you. I think you had a harder job. And I would not like to have to be on your side there to do that. My own feeling was that much of the evidence that you gave and that you had there was anecdotal, single case studies, and that it was the common fallacy of post hoc, propter hoc. And we know that's not right, because something happens after something else you cannot attribute, not necessarily attribute the result from what you think is a cause just because it occurred prior to it. You know? I feel that in the evidence that is presented, and that in fact the evidence came from the book there was much also ad hominem evidence, which is useless. He is a bad man, therefore what he does is bad and not good. You know, that is not evidence. So this is another logical fallacy, you know, that the author of this book attempted to foist on us. He said, well, these things happened after, therefore that's the cause of it. One, that doesn't go. Oh, the man is a bad man. He had some sexual misconduct, or he makes too much money, therefore he must make it because he is a bad man, and therefore his therapy is bad. I don't see how we can go there. Then there was a third error, was the unsubstantiated assertions, such as it is used to erase memories and used by the CIA as some type of, I don't know, physical restraint, I think. He gives no evidence for that. And even if he did, even if there was somebody in Washington doing that, it still doesn't bear on the question, is this thing good or bad? You know, the question, and that's the real question, is the harm that comes from it, if there is some harm, less than the good that comes from it? And as far as I can see, from what has been said here, and not from what I know, because my own feeling is that, I'll make a comment here, just as I'll step aside. When I first went into my own psychoanalytic training as a young psychiatrist, the senior man, as we were at a table like this, presented a case. And he said, what are you going to do for this case, Frankie? Frank? And I said, well, probably I'd start using medicines, probably. Oh, he said, you're going to be an analyst, you're going to use medicine? But at that point, what I was doing was, there was a comment in the book there, that's very true. The book's comment was, well, you do what you know. You know, if I did snake dancing, then I might say, use a snake and dance around it. You know, if I was the cook, I might say, try chicken soup. You know, you're an analyst, you try analytic work. By the way, that was another fallacy, you know, because that's what that's all you know. It's not really a fallacy. I mean, if that's what you know, that's what you do. But we're here trying to learn other things. So I think as I take it all down from what the evidence that's presented here, I would find for the defense of ECT, but say that you gave a hell of a shot and you had the harder job. And congratulations.
Are we allowed to comment or just ask questions?
Go ahead.
This is because it is a debate. I don't want to interfere between them. But indeed, I just have a couple of comments. I would really commend what Dr. Abdelrazak and Dr. Ahmed presented. Both are really strong. Indeed, when I came here, I had some doubts about where I'm going to stand. To be honest now, I know where I stand. And let me explain how. For me, psychiatry is not ECT. Psychiatry is biology, and biology also is not ECT. It is also chemical, it is ECT, and other surgeries. It is also social, it is also psychological, it is also behavioral, it is also psychodynamic. To take an act against ECT, it doesn't mean that we are crossing up all psychiatry. It is just an attitude in psychiatry or an approach in psychiatry. I tried here to collect the ideas of Dr. Ahmed, which was really nice, although he was defensive a little bit and he was taking another extreme stand, but I tried to collect his criticism of the ECT. One thing that it is effective. Nobody is denying the effectiveness of ECT, but this is not the issue. Dungeons were effective in the early years of treatment of psychosis. Chains were also effective. Some of the superstitious practitioners in our community in Upper Egypt are also effective. A policeman, when you violate the traffic light and they come and put you in jail for a whole or 3 months, is also effective. So the effectiveness is not the issue. Can we be effective with some other methods? Why we are against ECT? It could be probably that this guy, Dr. Bregan, he has some political or some philosophical trends, and we should not really just corner that away and say this is not appropriate. In the United States, there are many people are lobbying for ECT, and many people are lobbying against ECT. So it's not his problem to be, it happened by chance to be against ECT. So one thing, this is, I want really to remove the idea of effectiveness as an idea in evaluating the ECT. The second idea is brain damage. When I read in textbooks, all they say it is temporary, it can cause temporary memory disorders, and would subside after 2 or 3 days or so forth. Probably I will find in this material that Ahmed got from the computer, I have never seen a report about a whole neurological analysis. It only concentrates either on orientation or on memory. What about invading this whole brain? It is not only memory and orientation. There are many things in the brain, and we really don't know. And indeed, I might be interested to know from you if there's some research that I carried, because I am going to write an article about this. During my first years in practice in behavior therapy, I had confronted this same problem. I started with behavior therapy, and just by chance, I was against the early development in behavior therapy, the Skinnerian attitude. Some of the people used to harm patients when they are talking to themselves or do something wrong. They did spank them and they will stop it. When I talked about this, they considered me as anti-behaviorist. They forgot that we can develop our theories. It's not just to act for or support something that you might really find some alternatives. And when I am saying some alternatives, I don't only talk about love or something like that these guys talk about at Reagan, but I am talking about alternative from psychiatry itself. Psychiatry is psychosocial, psychodynamic. It has many ideas that can really be helpful in this attitude. The second idea that he says, Dr. Ahmad also, that it is public opinion. And as if the public opinion is not important. It is just, he's a layman, they talk about that, and what about us, the medical, excuse me, I think that we know better than those patients and this sort of thing. If you are in America, you don't say that. In America, you are the patient and you have the right to say wrong or right. Another thing that you say that also it is effective in suicide. Indeed, I worked in the United States about 13 years in most Michigan hospitals. Northville Psychiatric Hospital, Residential Care Alternative, Lafayette Clinic in Wayne State University, and by chance, practicing ECT was forbidden in Michigan. I have never seen it during my years of practice, successful suicidal attempts, although there was no ECT. I would like to ask the people who are using the ECT, when you ask them, we did not use it for years now. I don't use it myself as if this is a defense. If you know it is good, then use it for all depressed and suicidal people. So there is something that is there behind, tell us that we should really be aware of that. I don't know what is it. I might not be the most popular person here, but really we have to find some. Ahmed indeed, when he finished it, he said something really nice, and I would like really to go through it. There are many approaches. It is not ECT or anti-ECT. But one of his problems is why brain surgery? There's brain surgery also. Brain surgery is not psychiatry. Psychiatry, you know, it is psychosocial. Even if you tell me it is medical, biological or something, but I know it is psychosocial also. Why you invent the brain for something that can probably be cured by psychosocial influences? It is not neurology, it is not diabetes, you mutate the leg or the hand. It's different, this is real treatment. So this is my issue indeed. They leave us where we are. I don't say this is good or this is bad. I think we have to start from here that we have to come with an eclectic or combination resolution. For our department, I think if we think of the ECT, because there are many ambiguous points of view here, we have to put some limits on that. Not just a decision to apply ECT and the hell with other points of view. We have to come with a plan, gentlemen.
ECT is not the first line of treatment. Okay? It's the last line of treatment, if I may say this. So nobody of us would go direct and say ECT. First you would try ECT, يعني بالعربي sorry, آخرة العلاج الكي يعني I think ECT
is the last treatment is the cocktail.
Qatar is the last thing to do. So ACT is the last one, it's not the first one.
Some people use it as the last, but some people as use it as the first.
Before. Very few.
There's kind of abuse, even among. But indeed, this is where we are left now. I mean, this is something I'm not against. I'm not for it, because nobody convinced me with this something now. Really.
Well, if I may have a comment here, and step around the road here. All one has to see are those severely depressed, generally older women who respond to nothing and who get ECT, and after a while, they get well. That's what convinced me. I think ECT is an emotional issue. In the United States, there are lots of issues that bear nothing on the reality of the issue, but that people get an emotional response to it, like homosexuality. It's a big emotional response. It has little to do with what happens there. It's an emotional response. They're responding emotionally. ECT is one of those also, you know. A lot of and if there's an emotional issue, then it becomes a political issue. It has nothing to do with the medical aspects of it. It becomes a way to get votes, a way to control something else. Give an example. The American Psychiatric Association, just because they say something, don't believe it. Just because they say something, so what? They are a political body, you know. They, and I think wrongly, said, well, egosyntonic homosexuality is not an illness. And personally, that was a complete change of what happened all the way up to that point. Yeah. And what was the evidence for that? Well, I think they gave some kinds of evidence, but the real problem was that, hey, there was a large body in the American Psychiatric Association that lobbied for that, and it became a political issue. They were satisfying a faction, really. So because the American Association either is for or against something, forget it. You know, I think that has nothing to do with it. What you have to do is look at the literature. And I disagree with you on one point here. I think effectiveness is probably, in my way of thinking anyway, is the thing we look at. If something is effective, if it gets more on the positive side than on the negative, then I, as a physician, want to use it. You know, if we had something even hurtful that would be effective against AIDS, just effective, and if it made everybody as bold as I am, whatever, and do anything else to it, everybody would get it. Everybody. It makes no difference how much harm they did. You know, if they were able to get, and I'm making a general statement, which is always wrong, by the way, and I know that. But I think effectiveness is very important. You know, in my own way of looking, it goes down as some type of ratio with effectiveness versus the harm something does. It's something like the LD ratio, as we all learned about for drugs. You know, effectivity and how much damage it does. I think that's.
You're right.
In my mind, that's how I look at it anyway.
Yeah.
Whether it's right or wrong, that's how I
but that is
personally
correct. But when I'm talking about effectiveness here, if we have some alternative effective approaches also. Everybody tells me if we are in emergency and somebody coming with suicide or something like that, you don't mean that I cannot cure him by being friendly with him, by doing something other than ECT. What about the hospital that they don't have ECT?
Yeah.
People die, people commit suicide for
I
that.
don't think that's an indication for it.
Yeah, but I mean, effectiveness, if you have some other ways, why we have to use something that is really doubtful? I mean, you give me 1,000 paper, but I'm telling you, as you said, emotionally, I am against it. I don't like it. I don't want somebody to invade my brain. I probably prefer to take some Valium, to take some Triptizol or something else, but I really don't like to take
It's a last line
myself.
treatment.
I look at it the other way. I think it's is
Yeah, so
less
it is-
harmful to take tablets than to take ECT.
Well, for one night's sleep is not bad.
I think it's less harmful. ECT is better.
But I mean, this is why we call it debate. It is a controversial issue. It cannot be solved. It is emotional, as you nicely
That is why. It's also
stated.
very political.
It is very
Emotional
political.
and political, which we have to try to put aside.
Yes.
This book, and I totally agree with you, it's a very emotional kind of book. It's made for people who are against he's an anti-psychiatrist, like Fullatori used to be, like the guy up in Buffalo. What is this guy before him? Saz. You know. By the way, I spoke with Saz once, and I said, "Why are you what do you do then? You're a professor of psychiatry." I said, "What do you do? You're against everything." He said, "I practice psychiatry." In what way? Every way.
Good that you understand his language. He's really.
And he
his
was
language is very difficult. I heard him.
I asked him what he did in cases of you're against everything. What do you do? He said, I do just like you. Okay. He writes
So
books.
what I
That's what he
like,
does.
we expose
Yeah.
all ideas.
Yeah.
I mean, this is one of the good thing about this kind of debate indeed.
Very nice. Very
yeah,
nice.
it is exposing ideas, and I hope that before judging it, we could have split the group here, a group that we tell them that you are anti, and another group that you tell them that you are pro. And then we see how they will change their perception. It is really a matter of perception. I mean, well, Razak is not the best one who's presenting this, because I know him. He was really hesitant, anxious, and came to my office.
That's your battle. That's what it's good for.
Yeah, this case that he's presenting is brain damage. I mean, this is not the best case. Even though, man, even though if it is brain damage, it means that you are getting her worse. This is really make us more careful.
I am not Peter Brigham, Dr. Abdullah. And just I'm showing the view of this man. In fact, the topic and the title of the book is very attractive to the public. A psychiatrist,
Right, it is
it's a psychiatrist speaks out.
Yes.
Why therapy, empathy, and love must replace the drugs? Electroshock, even you call it electroshock, not electroconvulsive, and biochemical theories of the new psychiatry.
Yeah. And that word, right itself, shock.
Shock.
He just wants to sell his book as Ahmed told me.
Yes.
Bravo.
And survivor.
He
The
felt,
word survivor itself.
Yeah.
The word survivor.
Yeah,
This
he
is an
used a lot
emotional
of very, very
emotional word.
interesting words.
Yeah.
Survive
As
what?
if all people of ECT
Died
died
and
and
this-
only few survived.
Yeah, but excuse me, Professor Abdul. In the case, the most common cases that use ACT is the depressive disorder or psychotic disorder as general. In such cases, the patients are refusing to live. They are refusing to eat, to drink, or to take any type of medication. So by ECT, we are surviving their life.
Yeah.
We are not
Yeah, when it
damaging
comes to-
their life. It is not the matter only of suicidal attempts or. And
I really like
they are
one
also-
of those people answer the question. I don't
also
have
they are in a
to.
condition
I
they
don't
cannot
have to
take a
tell you
decision.
my point of view though, because I don't want to feel the only person who is really. I'm not against it, but
Yeah.
You can.
yeah, but you definitely many people can give you some
and
good
in most cases-
answers.
You are the only one.
No, because I worked in the state hospital, and you have many types of those people,
Yeah.
and there was no ECT,
And they are in a
and they
position
cured
that they
them.
cannot take a decision in which
Because
they are
as
good
Dr.
or bad.
Frank told you that we always start with the strength we have here. And thinking goes to the dominant idea all the time, and the dominant idea is ECT. But if you have, if we don't have here the government for prevented ECT from practice, people will not die. You can think of probably being close to them for a couple of hours, stay with them, give them another medication. It didn't, for me, after 15 years of practice, and I told you I didn't see a suicidal case without ECT. It means that it is really didn't make a lot to not to have ECT.
If I may say,
But
if I mention in relation to what Dr. Abdulrazak earlier said, that Ernest Hemingway, he committed suicide, he said, after taking ECT. His granddaughter just committed suicide 5 days ago, and she didn't take ECT. So,
Go for
There's too many contradictions in the literature. They said they were asking about the humility. The ECT is causing brain damage and so and so. But they are making an experiment on the animals.
Yes.
What about the living creature, right? The opposite part will make it hard for us.
I'm sorry, I just want to say something. I think ECT is still a very important procedure and dangerous procedure in a way. Otherwise, why should they take consent from the patient? Why should they put some investigation?
Excuse me, not from the patient, from the relative. Because the patient cannot take a decision.
It doesn't make a big difference.
Yeah, from relative.
But the
It doesn't make a
anesthesia.
difference. Does it make? If I get you a consent, what does that show? It shows that this is a very important things you're going to do. It's not an easy thing just to get out your abscess and so on.
Consent for two reasons.
No, let me just, I'll tell you. Second thing is the investigation. You are, putting the ECG. Why? There must be something. I mean, if they are confident that ECT is free of everything, they shouldn't. Why should they worry about the consent and the ECG? I'm trying to defend. Please give me just a small thing. To be on his side and trying to be your second man, in a way. And I feel so sorry that nobody trying to defend you, but it struck my mind.
No, I know it is not popular. It is not popular
So
case, but many things are not popular. It doesn't mean that they are wrong, though. Popularity is not the issue here.
This is a bias.
No.
ECT itself, and in the medical field, not even in psychiatry, other fields like neurosurgery itself.
We have,
surgery.
as you said.
We have controversy. And many doctors have been claimed that they are opening the brain of the people for their own interest, even to the surgeons. This issue is raised here and there and everywhere. But I think as we tried our best to do the best for the patient.
Right.
For the patient. And I think this is what I thought, and this is a healthy issue to discuss it in an open way. Really, in this hospital, Dr. Frank, we never have been done in this open way. To see this idea and the opposite idea in the same session, and we sit and discuss it. I think this is so healthy just to open our hearts and to speak out and just to learn from the people. It's just a matter of education. It's not this is with and this is against.
Right.
Just would like to learn and would like to know. From Saudi Arabia or from America or from USSR or from everywhere, the knowledge is for the human being anywhere. Regarding the emotional, I think any aggressive treatment anywhere, it raises emotional aspect of it. Amputation of a limb raises an emotion. Here in Saudi Arabia, one time, as my colleague said, and one of the friends that became a story in the public here in Saudi Arabia. In King Faisal Specialist Hospital, they decided to amputate a leg for a man. He's a doctor himself. Your leg is now not anymore painful, and gangrene is all over and need to be amputated. And King Faisal, the highest technical hospital in the country. An old lady came and saw this man and told him, no, I think I have a herbal medicine to cure your leg, just let me try. And she took him outside and she did try, and he came back with a healed leg. Complete, and it saved his power. The doctor got surprised. How this come out? What's being done?
These are anecdotal. You cannot argue against that. Because there's little there.
So,
There's little. I wanted to make a comment about all this money psychiatrists make. Very few psychiatrists practice ECT not because it is particularly dangerous, because it's really not. You have the figures, it's not dangerous, but because there's a lot of emotion involved around it. As regards of, and if in fact, and I seriously doubt those figures, by the way, seriously doubt them. Just because he puts them in there doesn't mean they're right. If people would make $250,000 working a few hours a day, I guarantee you there would be a lot more people doing it. But they don't, you know. The second thing is that when you do it, you have to pay much higher insurance. Your insurance is doubled. And I always wondered about that. You know, you're asking the same question. Well, why are they asking you to sign it if it's not bad? But I still think that does not compute. You know, it's the opposite way around. It's false logic, you know.
Yeah.
It does not. Because in the United States, and I think in most Western countries, but especially the United States, people are very litigious. Anything goes wrong, they want to sue. And who do they want to sue? You. So you want to sign everything down. Not because it's terribly dangerous, but you want to make sure that you have a defense. It's a terrible thing to say, but it's true, you know. So, in a way, it's not saying, well, why are you signing? You know, it must be bad. No. You sign because you're defending yourself, you know, and you're being defensive. You're practicing defensive medicine. Yeah. It's a different kind of. It sounds like it should be, but it's not. You know. And they do that, I guess, for the same thing. You know. So that's something they want to make sure. The doctors want to make sure that they are not held responsible, and that's about it. You know. In fact, the fact is, why take a chance? Why? You know, why should you take a chance? Sign the paper. Therefore, if something happens, even a dentist sometimes gets you to sign when he takes out a tooth. Yeah, so it doesn't make sense there. But there's very few people who use ECT, and I think that's sad. Most of it is confined to the public hospitals. The public hospitals, where those people who cannot afford medicine, they can't afford it. You know? And they're severely depressed, and they do get it. Some states, like Michigan, apparently, do not allow it. Again, it's strictly a political issue. There's a lobby in there that said we don't want it. It affected the kinds of people that make decisions, and they made a decision. And of course, they tried to get, you know, medical evidence, but when it comes to making a political decision, it's political factors that come into play, not medical factors. If medical factors came into play, then, you know, things would be a lot better, I think, but they don't.
And there is a good example of the idea of euthanasia.
Something happening right now?
Yes. Something not at all medical, and it's only political.
Yeah, there's all human or psychological conflicts, emotional.
I want just ask Dr. Frank, when I was reading this chapter, it was not that easy for me to read it, and not that easy to digest it, and not that easy to present it.
I know.
No, really, because it's not written. I'm now not talking as the
presenter.
Presenter. I'm talking as now again as one of the member of the group. It's not written in the way I usually read a scientific magazine. There is.
It is not textbook.
Yes. Yeah. There is data and there is scientific information. There is a tables. There is number of patients. There is a statistical study. I can present it, so I am happy.
There's no data there. Yeah, that's why we're having trouble. There's no data.
Yes, I write here and there my own comment to use it, and I find my mind still. It is written in the pure American way, and I think
it's written for the average person to read that and to make a decision. You know, so that decision has to be. It's only slanted one way.
Yes, and I think if it was read by an American citizen, it will be he will get some maybe other idea and a better idea of to present in a better way. You, Dr. Frank, now as an American doctor, how is the situation now in America? Really, there is outrage in America against ECT. The public is asking to stop the ECT. Really, Or and it is really it have been abandoned in certain states in America, or this is just an issue raised in this?
I think it's a local issue, you know, like all politics is local anyway. I think in most states that it is used. Some states are much, much more careful about it, you know, because it's so emotional. It's just nothing to do with its effectiveness or dangerousness. But there are some states that, especially those who are very, very interested who are interested in personal rights over everything. He has a right to die if he doesn't want to. Those kinds of states, you know. He has a right to be sick, you know. And you get into that kind of political atmosphere, then nothing, you know. Sometimes your hands are tied. It's the same thing with medicines. Many states will say, if the patient says he doesn't want medicine, you cannot give him medicine. Finished. That's it. And then you're very much trouble, you know. It's part of this whole movement, by the way, where the government tries to ensure personal rights, but when it does so, it's at the expense of good medical advice, I think. But, you know, that's a very difficult situation, you know. Personal rights are important. They're very important, you know. But sometimes you can't make a decision, you know. Especially in Alaska, you have to watch out. And we have.
Is it allowed in Alaska? The
Yes, yes, it's allowed.
In even governmental institution or just in private hospitals?
It's allowed in, there's only one governmental hospital in all of Alaska. It's in Anchorage, and it's allowed there. There's one psychiatrist in Anchorage that I know of anyway that does ECT. And you can call him, and he will do it. Most other people, you know, the reason why a lot of them don't do it is we have very effective medicines now.
Yeah.
We have effective therapies, you know, but occasionally there are some people who, for whatever reason, do not respond. There's plenty of them, you know, but if you know, in the whole United States, and those are the people that ECT seems to, you know, that works.
Yeah.
But there's, you know, you don't see too many others because we have medicines that respond.
You stopped practicing it, right, for a long time.
Yeah, I just practice psychoanalysis, really.
Yeah.
Yeah.
Was it emotional thing, or just you felt that psychoanalysis is stronger and more effective than ECT, or you just?
Oh, wait a minute. Now, I mean, analysis is not going to work on those people, really, who, you know, when you're so seriously depressed that you can't even think, then forget it. You know, you cannot. It's not going to work. You know, there's just, you know, analytic or dynamic psychiatry. I'm not trying to teach my teachers here, but it's only good for a certain percentage of the people.
Yeah.
You know, and you have to make sure you select those patients. Now, the range of analytic treatment has been widened, and a lot of it is heroic treatment. When there's nothing else you can do, you know, you can always do that, and you may never be able to help everybody, I mean, cure everybody, but you can help some, you know, and soothe everybody, you know. So it depends on your aim. What are you looking at, you know? I think all of our treatments have to soothe and comfort, you know, help as many as we can, and cure, you know, as many as we can. But that's the least number of people that we can do, you know. It is analysis is not in the same class as ECT at all, you know. But for some, I mean, I have treated a manic patient for 5 years and helped her very much, but she was still manic when I finished. She just didn't go into the hospital as often. She used to go every 3 months. When I finished, she hadn't gone for 3 years, you know. She was still manic. But
even after the...
Yes, yeah.
Interesting.
But I think there's a definite place for this. I really do. It's special place, like a special place of all of our treatments. We don't indiscriminately everybody who comes in the hospital, give them Thorazine, give them a, you don't do that. You know, we are selective in what we do. ECT is a place. You know, in my mind, it has a place. Anyway, and it's a minor place because our other treatments are much more, are getting more and more effective. We can reach a lot more people. And of course, you all know that. Really. Yeah.
May I please, just one point. I cannot see anything specific for ECT. What applies to ECT applies to drugs, applies to everything in medicine.
Yeah.
Because as we all know, every drug is a double weapon, or double-edged weapon, I mean. And just one point came to my mind now, the word physician in Arabic called Hakim. In old days, Hakim, in English, wise man. The old physician, the Arabic people in ancient times called the physician Hakim. And Hakim from Hikmah, wisdom. Hakim, this is a wise man. This is the main of the core concept of a physician. He is supposed to be wise enough to weigh the benefits and the drawbacks or risks of any therapy, any kind of therapy, whether it's ECT, whether it is surgery, whether it's drugs, whether it is psychoanalysis can be toxic to some patients, whether it is psychotherapy can be toxic to some patients. So I mean, there's nothing unique to ECT to discuss. This applies to everything. As known. What I see now is that we are heavily bombarded from political agents or from emotional public by this anti-ECT attitude. We are heavily bombarded, and we found ourselves now, the medical profession found ourselves in a defensive way, and we cannot defend ourselves. I think it's our duty as a medical body or a medical people to not to be in the defensive side. No, we should educate the public. We should, it's our duty to remove these fallacies from the public. It's our duty to educate them on a scientific basis. And to me, today it was the first time to know that there is a controversy in ECT. To me, there is no controversy according to my readings and my practice. And on the contrary, the more recent textbooks now are favoring and are assuring that ECT is now, after more recent work and more recent research, it proved now to be more and more safer than it used to be thought of before. So I read in some books that, very recent books, American also, that it is the duty of the doctors to educate patients and to remove all these deeply ingrained fears. And so I think it should be like that.
We're consultants to the people. We give them what we think is the best. They have the right to choose.
Of course.
And that's when it comes down to it.
Of course.
We don't have the right to insist.
No. Just some patients even refuse the medication. Some people, the drug, they sometimes have opinion about the drug. We have nothing to do. We tell them that this drug is better, and the final opinion is to you.
Yes, that's true.
So,
Thank you a lot for this, being judged for this.
it's fine.
معايا بس موعد دلوقتي.
Okay. Well, on behalf of all of you, of course, I wish to extend our thanks to Dr.
Oh, it's a pleasure, really.
Rankulardi.
You really surprised me, though. You made me judge here.
Well, I think he has been very informative and very neutral. In fact, although he would say a few words in favor of ECT, he is a man who is not practicing at present. He is a man, as you have known, who is primarily functional in the line of psychoanalysis and psychodynamic therapy. This is, of course, meaningful that one can be practicing in psychotherapy and at the same time understanding that there are categories of patients who would not respond to his modality of treatment, who would consider that there is a place for other things. This is a healthy attitude. An attitude of a person who, from the medical point of view, understands that not all cases are treated by surgery, or all cases by medicine, or all cases by physical exercise, but that for whatever condition you have to look for the most suitable, the most viable, the most reasonable, and most feasible mode of treatment. Of course, one got very interested in reading the book, and after this session, I will ask Dr. Abdel to give me the pleasure of going through the book itself, because you know, this man is talking as a psychiatrist who speaks out. And the word speaks out tells you that this is a confession. What he was speaking in, now he is speaking out, a confession. And people like to hear confessions. And if you address your book as these are confessions of a criminal or confession of a psychiatrist, you can guarantee that it will become a bestseller. And if it is a bestseller, it will be not in the libraries and bookshelves and bookstores, but rather, as you said, in supermarkets. This is very good. Of course, this does not mean that it is a bad book for that. It will be a very good book, and also addressing the public. And of course, it is so much addressing the public that it is saying that empathy and what? And love. You are supposed to love your patients. Empathy and love must replace other therapies. So you can see that what he is saying is that not empathy and love must well join, or must well supplement or combine with other therapies, not to replace them. Replacing therapies by empathy and love alone would only mean that you do not have ground for an illness that needs special therapy, anything more than these two. This is why they can replace it. And of course, if the issue is about ECT alone, one could understand that, well, some people may not be using it. But the issue is about the drugs, electric shock, and understandably biochemical theories. Not only about therapies, but even about biochemical theories of the new psychiatry. This is a very interesting book, telling, and I think you, that at least there is no place not only for ECT but also for drug therapy. This is a controversial issue. There's a lot of talk about it, and there are many views about it, but I think it is worth hearing. I have read several books about that in this line. Of course, one of the most monumental was The Myth of Mental Disease by Thomas Sass, and his second book, The Manufacture of Madness, which ran into millions of copies, and they brought him a lot of wealth. Well, let us again thank Dr. Frank Laudi. Let us thank Dr. Abdelrazak for his brilliant exposition of the topic and his strong argumentation, and Dr. Ahmed for his ruthless defense of his salary, and for everybody here who contributed very well additively, for Professor Abdel for speaking out from the
Speaking out, yeah.
the view of a person who really considers that ECT is bad, but not brain surgery, because brain surgery, there is a need, there is a disease there, but here there is no disease. This is the concept, in fact, of anti-psychiatry in general, that psychiatric illness is not a disease, proper disease. It should not be considered as a biomedic model, and it does not warrant the same invasive mechanisms or biochemical theories that are applied to other branches of medicine. If we are inside the boat, we have to, well, get well, to accept having it rocked now and then. I think that this is most of what can be said about this, and this has been a very nice presentation from everybody over here, from the floor, and again, thank you. And look to see you again and again.
Thank you.